So the syllabus is in the start here. And I apologize, I didn't have it visible until yesterday. Everything else, it defaults to not visible, and I must have just missed that. So, sorry. Right. So you know that the lab times just changed a little bit for section 1. So it's later. So section 1's time is this afternoon from 2 to 5:10. So that's a little different. The materials have not changed. You're still going to be using your Faber book. You'll still be using your RadTech Bootcamp codes. The objectives, there's a lot of them. I'm not going to sit here and read all of these. These are available here. And then the objectives are always in the module overview for each week. And you can see how in the module overview, how the course objectives align to the PLOs, the program learning objectives, and how the activities relate to accomplishing those goals. So you can look at all of that each week. These are our program learning outcomes. Grade schema has not changed. You still have to have a 79.5 to progress in the program, so that has not changed. What has changed for this semester, just a little bit, is your tests are weighted heavier this semester. Okay. So instead of 30%, I think it was last semester, they're now 40. Okay. So this is the breakdown. Tests are 40, homework is still 5, lab quizzes are still 5, lab practicals are 20, final exam practical is 10, and the final lecture exam is 20 for a total of 100%. I've looked at this 100 times, but just making sure. So that's changed just a little bit from last semester. Course policies, attendance is has not changed. It's still 10%. You don't want to miss more than 10% of a class. There's consequences to that. Okay, so the college attendance policy has not changed. It's still, if you have not been in class in 14 days, then you get withdrawn from the class. But we have a little bit stricter policy because you guys have seen how important it is to actually be in class and be in lab. So if you miss more than 10%, then there's some things that happen after that. If it's only one class, then I think you lose your right to earn PTO. So I'd have to look back. But those are in the policy manual, which is also in Blackboard. The tardiness policy, I did add it into the syllabus so that you don't have to look for it. So you get technically 3 free lates. Okay, so all we're going to do on that third late is tell you, okay, you've been late 3 times, and then then you will begin to lose points off of your grade. So make sure that you know that a late is, I sit here literally and look at the clock and I wait until a minute has gone by. Okay, so like last semester, when it hit 8:02, that's late, right? 8:01, I'm sorry, 8:01 is late. 1 minute is late. So this semester, I'm going to sit here and look, 7:31 is going to be late. And the reason we're so strict on that is because that's the way most of your employers are going to be. 1 minute late is late. And you get written up after a certain amount of those lates, and then you can get, fired, terminated for being late. So it's important that you be here on time. So that's where this policy is easily found now. It's also in the policy manual, but now you can see it here. Tests, quizzes, practicals, none of that has changed. You're still going to be testing online. Just a few things to remember. Your room scan is very important. We need to be able to see your entire desk, under your desk, and all 4 walls around you. Okay, so that's what your room scan should include. Again, dress as if you're coming to, God bless you, coming to campus. Your whole face should be visible at all times. Now, when I watch the videos and it gives me flags that your face is not in frame, most of the time it's because you're looking down working, and that's fine. I get that because you have a lot of math on my test. So the thing is, you don't want to be your whole body to be totally removed from the frame. So make sure that you don't do that. No hats, no vaping or smoking. Of course, you cannot use any other electronic devices or resources. So, and I do watch those videos because I get a kick out of them sometimes when y'all's animals don't behave and things like that. But anyway, so the testing is going to be very similar to last semester as far as like mostly multiple choice. Sometimes you'll have math to do at the end where you can always have a blank piece of paper as long as you show it during your scan, and you can always have your calculator. So it should say that in the instructions, but if it doesn't, know that you are allowed to have blank paper and your calculator for every test. Make sure that you're bringing your lead markers and your radiation monitors to lab every week. If you don't have them, especially on a practical day, you're not allowed to do the practical. So if you get here and you realize you don't have it and you have time to run home and get it in between, that's fine. But otherwise, you're not allowed to do the practical. Here's the link to the policy manual, the health sciences handbook, and the risk manual if you have need of that. I'm not going to sit here and read all these institutional policies. They are here for easy access for you. This again talks about testing with Respondus Lockdown Browser, which is what we use. This is the attendance policy, meaning if you have not been in attendance for 14 consecutive calendar days, including weekends, holidays, college breaks, and canceled class sessions. It doesn't matter if there's been a holiday in there. It's if you have not been in class, for us to count you here in 14 days, it removes you. So we don't love that either. I don't know why they would include holidays when you're not even here. Nobody's here. But that's the way it is. And so that's what we have to go by. This is all, so dropping, adding, withdrawing from courses. Hopefully we don't have any of that happening. Pass, non-pass is, I was thinking was only an option for non-programmatic courses, but I'll have to look into that. Regardless, you still have to have the 79.5 to consider it as a pass. Incomplete. Sometimes this does happen if somebody has some kind of health issue that mostly affects clinic, then we can give an incomplete until you can get your clinic time made up, and then us have the grade change to whatever you earn. So unfortunately that happens sometimes. People have health issues that they're not expecting to come up, or emergency surgeries, things like that. So we can deal with that on a case-to-case and do an incomplete if we have to. Academic coaching and tutoring. If you find that you are struggling in a class, we're going to probably reach out to you first. But if you feel like you need some additional help, let us know. Let either me, Yolanda, any of the instructors know, so that we can get you hooked up with a senior tutor. We use our own students as tutors. And so I think maybe a couple of y'all did that last semester. So that often is helpful just to hear it from a student's perspective. Sometimes it can help. If you need any kind of accommodations, then you do have to go through the Student Disability Services office. Really, the only accommodations that we've ever needed were extra time on tests and a quiet place to test. And now that's sort of been removed from our responsibility because you're testing from home. So it's sort of your responsibility to find a quiet place away from your family or whoever. If you do feel like you need extra time on tests, then you have to go through the Office of Student Disability Services and get an accommodation form and then get that to us. And I think I have that due next week, like by the 23rd, if you need that, so that we can go ahead and get that in place. All this other stuff is just here for your information. Schedule is available here, and then also as a I'm going to look at it. Let's go to the welcome course overview and schedule. So you can see again here all the objectives. Here's the grading component, and here is another way to look at the schedule if you like to look at it this way better than in the syllabus. It's the same thing. You can see what we're going to be doing for lecture. You can see what you need to read prior to coming into lecture, what we're going to be doing in the lab, and then what's due for homework. And so you can see that your syllabus test is open until next Monday night, midnight. I gave you an extra day since it's a holiday. Figure not why make it due on Sunday night when Monday's a holiday. So so your syllabus test is due by midnight, January the 20th, which is next Monday. You also have these due again through Monday of next week. Now, typically it will be Sunday night that things are due, just like last semester, but giving you that extra day since it's a holiday. So you will have your RadTech Bootcamp collimation, filtration, and then filtration measurements due. That's for next week. Instead of giving you page numbers, that's such, not page numbers, but well, yeah, page numbers in the midweek reminders. That's a lot of work for me to keep up with when RadTech Bootcamp moves stuff around. Okay, so I'm constantly having to look and see, well, where has RadTech Boot, have they moved this and put the page numbers in the lab manual, in the midweek reminder from the lab manual. So this semester, what I've decided to do is just give you the exact title of the assignment, and you can put that in the search bar very easily and see, click right on the assignment instead of me having to drill down each time and tell you, okay, go here, then go here, then go here. That's a lot of keeping up with. So in your search bar in RadTech Bootcamp, if you just put in collimation, then you should see it pop right up and you click on it, it'll take you right to that lesson. So that's how we're going to do that a little bit different this semester. If I want to go ahead and address this. So next week, of course, we won't be here on Monday. So we will miss lecture, and section 1 would miss lab. So what I decided to do a couple of years ago, when it's like that from the very beginning of the semester, it's very difficult to have one section out of sync with the others in lab. So next week, section 2 and 3, you will not have official lab for me. Okay, we can do open lab. So if you need it to do something for Yolanda, you certainly can do that. Section 1, if you need to come into either one of those labs to do something for Yolanda, meaning if y'all don't finish peer reviews or whatever, we can do that. But we're not going to officially be having my lab next week because it would get us off a week. And it's just hard to keep that straight. I can't start new stuff in lecture if one lab has not had the previous material in the lab. So next week, lab for my class will be optional. Okay, so sections 2 and 3, you don't have to be here, but it will be a great time if you need it for Yolanda's, because this is, again, the first lab back with Yolanda, and you know how intense those labs are, and we need every second we can get in there. So So that's worked out well the last couple of years. It's actually worked out well too because of weather. So it sort of creates just a little bit of wiggle room in the schedule if we do have bad weather towards the beginning of the semester. So any questions about that? I'll of course put all of this in the midweek reminders so you can remember, but even though we're not having lab, look at how much homework you have. Okay, so there's a lot. There are 1, 2, 3, 4, 5, 6, 7, 8 videos you have to watch. Now, granted, they're like 3, 4, 5 minutes long, but there's a lot of them. So you see that ahead. You can go ahead and be working ahead if you want to. But you will have these that will be due the Sunday night, the 26th. Okay, so let's see, wait a minute. Yeah, that jumped to another line. I hate when it does that. Anyway, so any questions? Yes, ma'am.
What time is the open lab at, since it's for both sections?
It's the normal section times.
Oh,
So it's
okay.
like section 2, I think, is from 7:30 to 10:40. Yeah, section 2 is from 7:30 to 10:40. And then section 1, y'all, no, wait a minute. Section 2, it goes 2, right? Are y'all back to back on Tuesday, section 2, with me and then Yolanda? Okay, so it would start at the normal time. And then section 3s would be from 2:30 to 5:40. So that's a late one. But that's what y'all did. No, section 3 had that last. That is section 3. Oh my God. I'm so confused because it changes this semester. So yeah. So my normal lab times for Tuesday have not changed. They're still starting at 7:30 and starting at 2:30 with Yolanda's mixed in the middle. Any other questions? And so if section 1, if y'all want to if you need to come in, you don't have to let me know. You can just show up. Should be fine because our numbers have dwindled a little bit. So, and then you can just go through and see the rest of the course schedule. We'll look at it week by week. Here is the important dates listing. The testing schedule. And so we'll talk about that QC test. That's going to be towards the end of the semester where we're doing those QC testing activities, excuse me, in the lab. So we'll look at this in detail each week. Any other questions about the schedule? Okay. Let's see if there's anything else in here. Here's the syllabus test. You should be able to do it as many times as you want because you have to get a 100%. That serves as my syllabus receipt. So take it until you get a 100%. You certainly can access the syllabus to answer the questions. That's the whole point of it. I don't expect you to memorize the syllabus, but sorry, I do expect you to be able to pull the syllabus up and find the answers in the syllabus. So do that as many. You don't have to do it under Respondus or anything. It's just as many times as you need to. Excuse me. Other resources that you may need, you can find in this link. Here is your lab manual. You will need that before lab. We have a lot of activities that we're doing this week in lab. I think there's like 6 different things. So you need to have access to it either on your tablets or your laptops or in printed copy. If you don't have it, you're going to be lost. Here again are your Rad Tech Bootcamp instructions in case you sort of forgotten a little bit about how to do that. Okay, and so week 1, we are going to pick up with beam restrictions. So you can see here's a PDF of it. There's an optional soft chalk lesson if you want to do it. Again, that's not anything that's required. It's just there's extra material for you to have to. I am so sorry. I haven't talked like this for a couple weeks now. So I got to get back in the groove here. Okay, let's. Oh, I didn't even do that. Let's pull up beam restriction and filtration. So you already know the term beam restriction, collimation. We can use those interchangeably. They're talking about the same thing. So we're going to look at how scatter radiation, and we've talked about scatter, but we're going to talk more about it, get into it a little bit more detail this semester. We're going to talk about the different types of beam restricting devices, the purpose of automatic collimators or PBL, positive beam limiting devices, what that means. And then we're going to talk about filtration and how it affects the X-ray emission spectrum. And so all the activities that, does anybody have like a little mint or something? Anything? Yeah. You don't mind. A golf drop, anything would be fine. He's got one right here now. Thank you so much. Got to bring my water. Thank you. So we're going to actually, in lab, do some activities with not only beam restriction, but filtration. So there's a option on the interface, the user interface on the front of the tube, where we can add filtration in. We're going to see how that affects the emission spectrum. So Compton scatter, if you remember, it's supposed to be a little video. Let me see if it'll play. It's the interaction of a photon with an outer shell electron, where the photon changes direction and it has less energy than it did before the interaction. So you can see the photons coming in, interacting with an outer shell and going in a different direction. So it doesn't have as much energy as it initially did, and it's now going in a different direction. If you look on page 51 of your Farber book, you can see a nice little box that talks about scatter and sort of walks you through the steps of that to help you understand that a little better. We know that Compton scatter is something that we want to try to prevent as much as we can from reaching the IR because of those reasons, because it's now going in a different direction. So it's not an accurate representation of the anatomy. It adds a little fog across the entire image. I'm sorry, y'all. I'm really not sick. Okay. I don't know what's happening here. So, photoelectric effect is the interaction of the photon, typically with the inner shell, which results in characteristic photon as secondary radiation. That can be found on page 50 of your Farber. If we watch this little video, you can see that photons coming in, interacting with an inner shell, and outer shell is dropping down in that vacancy. And you see that that secondary radiation is coming off of that right there. Okay. Generally, that secondary radiation is just absorbed immediately. It has very little energy, and it really typically doesn't ever make it out of the patient's body. So Compton scatter is with an outer shell. Photoelectric is with an inner shell. Now, the two major factors that affect the interactions is kV, kilovoltage, and the volume of irradiated material. So volume meaning the field size, how much of the body is being exposed, and the patient's thickness. Okay, so those are going to affect the interaction. So we said we had those two main interactions, and the third thing that can happen to the photon is what? It can either be scattered, Compton scattered, photoelectrically absorbed, or transmitted, pass on through with no interaction. And the controlling factor of that, meaning something that we can physically control, is the kilovoltage. So if we increase, and this all should be reviewed right here, okay? So if we increase the kVp, that decreases the total number of photons that interact because there'll be more penetration Okay, transmission is going to increase. Overall, in general, overall, when we increase KVP, there's just going to be fewer interactions that happen. But relative to one another, meaning when we look at photoelectric and Compton comparatively, when we increase the KVP, there's going to be less photoelectric relative to Compton. The scatter is also going to be more forward in direction, so it's going to be more likely to reach the IR. That's at higher KVPs, okay? So generally, how does increasing the KVP affect the patient's dose? Generally, it's going to decrease, and that's based on a couple of things. Because of the decreased photoelectric absorption, meaning more photons are going to make it through without interacting when we have higher KVP. And what do we typically do if we increase our KVP and we want to maintain receptor exposure? What do we have to do? Decrease the mass. And anytime we decrease the mass, we're going to decrease patient's dose. Okay, so that's why generally we say if we can use higher KVPs, it's better for patient dose. And I think even last semester, there was a test question. Maybe it was last semester. Maybe I'm giving you the answer to a test question this semester. I can't remember because I've been looking at this semester, intermingled. So I can't remember what's what. If you have the options of setting a technique, say 90 at 10, or 80 at 20, or 70 at 40, which would be best for patient dose? Which one? Yeah. The higher KVP with less mass would actually be the best for patient dose. Okay. So, how does increasing KVP affect subject contrast? Well, it decreases it. We know that because decreased photoelectric absorption, more photons are going to make it through the patient without interaction, and there's less differential absorption, meaning the part is going to become more uniformly penetrated, right? When we increase KVP, subject contrast is going to go down because the part's going to become more uniformly penetrated. In other words, the brightness levels, the shades of gray are going to get closer and closer and closer together. Okay? So again, all this should be reviewed. Hopefully it's coming back. Now let's look at the opposite. So we've been talking about increasing KVP. Let's talk about decreasing KVP. Decreasing KVP increases the total number of photons that interact because transmission or penetration decreases overall, in general. Relative to each other, you're going to have an increase in the percentage of photoelectric relative to Compton. There's going to be, as the KVP goes down, there's going to be more of a chance that the photon's actually going to get absorbed because it's going to have less penetrating ability, less energy, less ability to make it out of the patient. The scatter is going to be less forward in direction, so less likely to reach the IR, which is why we sort of say when the KVP goes down, we have less scatter on the image because there's, number one, less chance of it, and it's more likely to just go off in a different direction and not hit the IR. So how does decreasing KVP affect the patient dose? Generally, it's going to be the opposite of what we just said. It's going to increase because more photons are going to interact with the patient. And typically, if we decrease the KVP, what do we have to do to the mass to compensate? Yes. If we're changing it by 15%, then we have to double the mass. So that means more patient dose. How does decreasing the KVP affect subject contrast? It increases it because we're going to have more differential absorption. Remember, differential absorption means body parts absorb radiation differently. And that is because of a couple of things, but the controlling factor of that is KVP. So if we decrease KVP, then those photons are going to have less energy. They're going to have less penetrating ability. So there's going to be more of a chance that they're just going to be absorbed, which is going to create more differential absorption or more difference between the way the body parts absorb the radiation. So that was KVP. Now let's look at the volume of material and how it affects scatter production. So field size. Increasing the field size or opening the collimator increases the volume of tissue irradiated. That just makes sense. If you go from this much collimated field to this much, by opening the collimators out, you're exposing more of the patient's body. So you're increasing the field size, increases the volume of the tissue irradiated. There's going to be more photons available, more matter so to interact with, which results in increased scatter production and lower contrast. So this is something you got to grasp, because we're going to be talking about this in lab. We're going to be talking about, okay, how do we adjust our technique to compensate for that less scatter or more scatter reaching the IR. We got to look at that. So if you decrease the field size, it decreases the volume of tissue irradiated. There'll be fewer photons available, less matter to interact with, which decreases scatter and shortens the scale of contrast in the image. So for example, we're actually going to do this in lab. If we start out with let's say that's a 14 by 17 field size, that large one. Okay, and that's over the spine. So if we decide, okay, we used to do these routinely, and I know Greenville Memorial still does, but a lot of places don't. But we always did an L5S1 AP spot, and I realize y'all are getting ready to get into spines this semester. So we'll talk about this more. But we always did a little collimated down spot of L5S1, like you can see on the picture on the right. What do you notice about the displayed contrast between the one on the left and the one on the right? Which has higher displayed contrast? The one on the right. And you say that because why?
It's more white than black.
Yes. So more black and white. What were you saying?
Oh, I was just gonna go back to what you're saying about the size. Like it's smaller so you can see it better.
You can see it better because the visibility of detail is better, because there's less what reaching the IR on this one. Scatter. Right? We've gone from this big, that's really big, from this big field size down to this little square, okay, of L5S1. So now that's less matter, right? Smaller field size, so there's going to be less scatter. Therefore, anytime there's less scatter on the image, what happens to contrast? It goes up, right? It goes up. So what's happening here is we have narrowed down the field size, so we have less matter, less scatter that's reaching the IR. Therefore, contrast is going to go up, display contrast. Okay. Shorter scale means more black and white. Okay, so decreasing the part thickness is not really something generally that we can control. I mean, a patient is as thick as they are, and there's not a lot we can do about that. But one area where you will see the technologists be able to help with that a little bit is in mammography. Okay, so you guys are really young, so probably none of y'all have had a mammo yet. But when you have a mammogram done, the breast tissue is compressed down like a pancake, right? They try to compress that tissue down. And decreasing that patient thickness results in lower patient dose because the part is now not as thick as it was. It's more spread out. With mammo, if you're using AEC, that's going to turn off earlier. That's going to bring the tissue closer to the IR. And those are all good things. Okay, so that's why you want to try to do those things when you're doing mammo. But otherwise, there's not really a lot we can do about patient thickness. That we used to use compression bands for things like IVUs, and that helps a little bit. But the patient's thickness is sort of just however they come in is what you get, right? But the thing that we can control is the beam restriction or the collimation. So it limits patient exposure by keeping the field size to the anatomy of interest, which reduces unnecessary tissue exposure. It reduces the amount of scatter produced within the patient. So again, beam restriction or collimation is a way that we can help to keep tissues that don't need to be irradiated from being irradiated and helping the quality of our image. So when we say we're increasing collimation, think about it this way in terms of if you increase collimation, then you're collimating more. Okay, increasing collimation means you're collimating more. So the field size is doing what? Getting smaller, right? So if you are decreasing collimation, meaning you're collimating less, your field size is getting larger. So you have to see how you could get that mixed up. But always ask yourself, okay, if I'm increasing collimation, that means I'm collimating more. If I'm collimating more, then that means my field size is going to get smaller. You can also look at page 176 in your Faber book for a little bit more information on this. So let's talk about collimation and scatter. As collimation increases, meaning we're collimating more, the quantity of scatter decreases, so image quality improves. So when we collimate more, we're going to have less field size being exposed, right? Less matter, so we're going to have less scatter, which is what this is talking about. So image quality is going to go up. Anytime we can get rid of scatter, image quality is going to go up. As collimation decreases, the quantity of scatter increases because now we're exposing more field size on the patient. So image quality is going to be degraded. So there's a trade-off. By decreasing the field size, image receptor exposure is decreased due to the decrease in scatter contributing. So even though it's unwanted, it is still a part of receptor exposure, right? Scatter is still a part of receptor exposure. The receptor can't distinguish between primary and scatter. It just knows it's being exposed, right? So when we decrease the field size, the image receptor exposure is going to go down because we don't have that scatter contributing to it anymore. Does that make sense? Okay. So generally, you have to increase mass if there's a significant reduction in field size. Because our goal, again, is to maintain receptor exposure. That's been our goal from the beginning of last semester, right? When we're making all these changes. So if you look on page 175 and 176 in your Faber book, it talks about compensating for differences in collimation. And it says it's been recommended that significant collimation requires the mass to be increased by 30 to 50%. So the multipliers that we use is we say, okay, if we're going from a 14 by 17, we're going to do this in lab, you're going to get some practice on this math. If we're going from a 14 by 17 down to a 10 by 12, then we need about 30% more mass to compensate for that loss of scatter that we no longer have. If we're going from a 14 by 17 to an 8 by 10, which is even smaller, we need about 50% more, okay? So for example, if we're going from 14 by 17 to 10 by 12, we would increase our mass by about 30%. And we will do some problems like that in lab where we use that multiplier. and you say, well, isn't that worse for the patient if we have to increase the mask? What you got to think about is you're exposing less of the patient's body. So the trade-off really is better for the patient. Even though we're having to add a little mask, we're exposing less of the patient's body with that mask. Does that make sense? Okay. So some different beam restriction methods. Keep up with the time here. Okay, beam restriction methods. If you look, I'm trying to give y'all reference pages in your FABR, even though it's on the schedule there. I'm trying to add those in a little bit to give you places to look in your FABR book, because our stuff is so spread throughout that book. It's not like Yolanda's where you do a chapter at a time.
I love that, so thank you.
You like this?
I love that you're putting the page.
Okay, good. I'm trying to, and plus we get a new, well, it won't affect y'all, but we have a new edition that I've got to go through and redo all the page numbers. Every 3 years this happens, because they put out a new edition every 3 years, and so everything changes. So there are aperture diaphragms, which is just basically a piece of lead with a hole in it. There's cones, and there are collimators, which is what we typically are using these days. Some of these others are older technology, but we still have to talk about them just a little bit. The aperture diaphragm is very simple. It's a lead line or lead plate attached to the tube. It can also be homemade out of like rubberized lead, which is like if you took the lead out of a lead apron, you could cut a square and cut a hole in it and do the same thing, is what that's talking about. Rare that you're going to see, I mean, unless you go to work in some place that equipment is super, super old, you're probably not going to see this type of beam restrictor. Well, one place you may see it is in fixed applications, where if you can see on this one, like with dental, or on this one, this is fairly new piece of equipment, but see how everything is connected. So the tube and the IR move together, so you can't move one without the other. And it's a fixed SID, like in other words, you can't bring this SID any more than where it is. That's a standard 72-inch SID. And so you might see something in like a dedicated chest room like that, or a trauma C-arm. We don't have those at Memorial. I'm surprised that they haven't gotten them at this point, but anyway, so if it has a fixed SID, then you could use it. Why could you not use it if the SID can change? Because it changes what? Yeah, the size of the field. When you move the distance, it changes the size of the field. So what it's saying is, if you had moved back more than 72, moved in more than, say, 40, it's going to get, the field size is going to get really small, and there's nothing you can do about it. Okay. Extension cones and cylinders are a variation of the aperture diaphragm. Cylinder, of course, is the same size all the way down, and the cone flares out and allows for the divergence of the beam. Again, you're probably not going to see these used. We used to have them in the old building, but we didn't bring them over. Applications for cones and cylinders were we used them in head work. A lot of times we had these old, what we call head units. For spine work, for cross table hips, it gave greater visibility excuse me, of detail. And that picture sort of looks blurry when it's magnified like that for y'all. But what do you notice about the contrast from left to right? Which one's higher? Yeah, look around the orbital rims. It's much wider in the one on the right. That's because that circular attachment was placed onto the tube, and so it got rid of all that extra scatter, so it improved contrast. So we used to use them, but I don't know that you'll ever see anybody using them anymore. If you look on page 173 of your FABR book, it talks about the collimators, which is what we're used to using. That's what y'all have been using in the lab. It's flexible, can be used at any SID because we can adjust it, right? And of course, it is the most expensive of the beam restrictors. It helps also reduce off focus radiation from reaching the eye. Do y'all know what off focus radiation is at this point? We might have talked about it just a smidge last semester. Off focus is that radiation that is created somewhere besides at the target in the tube. So we don't like that radiation, right? We want that radiation that's created at the target and comes down in primary that exits the window and is directed at the patient. And so there's a video in, let's see if that's for next week in your Rad Tech Bootcamp about off focus. It's very short, but it'll help you understand that a little better. So the first set of shutters, and this picture is in your book. The first stage is the entrance shutters, and those are located immediately below the tube window. And these can also be in the form of aperture shutters. And then you have the ones that, so this first stage shutters, we don't control that. That is built in, okay? What we control is the second set of shutters. And the length and the width of the field are independently controlled. So we can narrow it in the width without changing the length if we want to, or we can leave the width and do the length, or we can do both. So the length and width are independent of one another. The light field is a reflection off of a mirror that projects the coverage of the X-ray beam, and its proper adjustment of the mirror is necessary to accurately display the location of the exposure field. Needs to be accurate within plus or minus 2% of the tested SID. We're going to check that towards the end of the semester for each of the 3 rooms. So you guys, as you've been patients for your classmates, as you've been the patient and you're laying there looking up, have you seen the mirror up in there as you've been the patient? Yeah, maybe not because y'all haven't done head work yet, but you'll start to notice it. When you're laying there as the patient and the tube is up over you, you can see the mirror. So it's important that the mirror stays where it's supposed to, right? Because if it shifts, then that shifts what? The light, right? So if the mirror gets off, then where the light's being projected is not going to be an accurate representation of where the radiation field actually is. And so that's what we're going to be testing in a few weeks or a few months to see if it's accurate within plus or minus 2% of the tested SID. PBL is positive beam limitation device. It automatically collimates the beam to the size of the IR when it's used in the table or the wall bucky tray, because there's sensors in there that sense the size of the IR. So when we had small IRs, okay, we didn't have just the one big size. When we had the small ones, it wouldn't open up any bigger than the size of that IR. And that's important. Why? Why is it important that the light not be any bigger than the size of the IR? Yeah, because there's no IR out there to receive that radiation. So why expose the patient to that if there's no IR to receive it? Now our IRs are basically one size. Some of them are still 14 by 17, and some of them are square, right? Have y'all been out where there's squares anywhere? Okay. So now what happens, well, take for instance with our equipment, built into the software for whatever projection you're doing, it generally will open out to a particular size. So if we're doing chest, then it's generally going to open out to 14 by 17 or that, you know how it does 13.9 by 16.9 or almost 14 by 17. Whereas if you select knee, you'll notice that it usually opens up to about a 10 by 12 because it's trying to prevent you from leaving that thing wide open 14 by 17 for like a knee when you don't really need to. So with ours, it's built into the software, the projection that you choose. Whereas with the older ones, when you had different sizes, it would just sense the size that you were putting in there and it wouldn't open up any bigger than that. It was possible to override the PBL, the positive beam limitations, with a key. So you may have been out there in clinic and seen them turn a key. Has anybody seen them do that on the tube? Like turn the key so they can override for whatever reason. Hopefully it's not to just open the collimator up huge and not have to worry about it. Proper collimation is the responsibility of the radiographer. Never should be larger than the area of interest and never larger than the size of the eye, or there's no need for it. So, some breakdown of it. With a larger field size, meaning less collimation, so larger field size, you're going to have increased scatter because you're going to have more matter, more scatter. You're going to have increased noise because scatter is noise, a form of noise. You're going to have decreased signal to noise ratio, meaning decrease in the good signal to the noise, and you're going to have decreased contrast. On the other hand, with a smaller field size, then you're going to have less matter, less scatter, which means less noise, which means better signal to noise ratio, and increased contrast. So smaller field sizes give you all these good things. Now, sometimes we have to use larger field, like abdomens, things like that, spines. But that's just breaking down what happens when you change your beam restriction. Ancillary devices, things like lead blockers and lead masks. You have to check your vendor information for digital systems before using lead blockers or masks. Meaning if you put a lead blocker, and we're going to do this in lab, that's why I have so many activities this week. We're going to put a lead blocker behind the patient. Have you seen anybody do that in clinic when they're doing lateral, like lumbar spines or sacrum coccyx or thoracic spines, where they just butt up a little bit of lead behind the patient? Anybody seen that? Makes me sad. Well, I'm going to show you how to do that, and you're going to see how to. I know that St. Francis people, I know that Heather O'Shields does that. So if you ever work with her and she's doing spines, you're going to see her put lead behind the patient. It's just but you want to be careful that you don't get the lead too far into the field, because that's where it can mess up your exposure indicators for your digital system, which is what this is talking about, this sentence in bold. So lead blockers block scatter from reaching the IR, does not affect the amount of scatter produced. Only for image quality. There's no effect on the patient's exposure, but it does improve contrast due to absorption of the scatter prior to reaching the IR. So let me show you. So there's 3 different pictures here just to help show you what's going on here. So if you're doing like a lateral lumbar or a lateral, especially sacrum coccyx, that is the thickest part of most of us, right? There's going to be a lot of scatter produced because also our KVP is what? Higher, right? When we're talking about lateral spines and laterals through the pelvis, our KVP is higher. We're going to have more scatter produced naturally. So what we can do to help with that is not change the amount of scatter that's produced, but change the amount of scatter that reaches the IR by placing a lead blocker right up behind the patient. And so what that does is that helps absorb scatter before it makes it to the IR. So we're going to actually do that in lab and show you how much it improves your image. Lead mask made in specific shapes for specific procedures. It's attached to the face of the collimator. This is on an old arteriogram. So again, unless you're working in special procedures or something, you're probably not going to see this done, but we do have to just mention it. Back scatter is scatter coming back toward the cassette or IR from interactions in the floor or wall. To avoid it, the back of the cassette has higher attenuation than the front, and you can put a piece of lead behind the cassette. So where this came into play with us was when we were doing cross-table lateral spines, say on patients on backboards that come in through the ER. And they don't leave them on the backboards like they used to. But we would, let's say this is the wall, and we had the patient, you know, oh well, let's go with that. Butted right up against the wall, and they're on a backboard. They're laying there. We're having to do cross table laterals. We would place the grid right beside them, and a lot of times we would put lead behind it because they were right up against the wall. So what would happen is you're using pretty big amounts of radiation on a lot of those patients. And so what would happen is you get that scatter from the wall that would come back and try to expose the cassette. So we would put lead there. That's why the cassettes used to be made with the back of it being higher attenuating than the front. So beam filtration is the last thing we need to talk about. Good, we still have about 15 minutes left to get this in. So pages 39 to 40 in your Fogger book talks about and has this picture right here, looks right there that you can look at, but inherent filtration. So there's a difference in what we call inherent and added, and it can be a little confusing. Inherent is in the design of the tube. It's permanently in the path of the beam. There's nothing that we can do to change that, okay? Added is filtration that is added to the port of the X-ray tube. Now, even though it says added, a lot of times it's not something that we would add. It would be something that like a physicist or a service engineer would add, okay? So inherent is what's built into it, permanently in the path of the beam, and added is past that. So if you look at this picture, you can see that the inherent filtration includes the envelope of the tube, the insulating oil, and the window. So you can see inherent here has the thin wall of the envelope, the insulating oil, and then the window. That's the inherent. Typically, that is going to be anywhere from 0.5 to 1 millimeter of aluminum equivalent, okay? Added filtration occurs outside the tube and housing. So if you look at this, it says it's going to be aluminum, but sometimes it's aluminum, copper, or clear lead. The collimator also acts as added filtration, the collimator mirror, that mirror that's in there. So if you see here, this is past the inherent right here. And then this mirror also acts as added. So that's why I'm saying, even though it says added, it's not like really we're adding it, okay? However, some equipment does have the ability to have the technologist be able to add filtration. In our old room, it was a wheel, and we had a little wheel, and we turned that little wheel. With our rooms, it's on that interface that I was telling you about. So we're going to be able to touch it and add filtration. 0.1, 0.2, 0.3 is what ours will give. So you can see that sometimes, and it'll tell us on the face of it that it's aluminum. Some of them have a combination, have aluminum and copper. I know that the ER room at Memorial that everybody hates, y'all know that one I'm talking about that nobody wants to use. On the face of it, there's a little button, unfortunately, right beside the collimator light button. And so if you ever you're using the room and all of a sudden it just seems like it's not shooting right, like your EIs aren't coming out right, make sure that you haven't accidentally added filtration there, because it's easy to hit it because it's right next to it. I don't know why they designed it that way. So right beside where you turn the collimator light on, you can add some filtration there. So the term compound filtration is on the specs that we have to talk about. It just means that more than 2 or more materials that complement one another are being used. And typically, that's going to be more like in radiation therapy. Normal filtration that's used in diagnostic is referred to as flat filtration. It's usually only one material. So how does it affect the average energy of the beam? So if we look at an unfiltered beam, which is on the left, you can see that the KeV of the photons ranges anywhere from 30 to 70. Okay, so the average, if we add those up and we divide by 5, the average energy of those photons would be 50. Okay, if we add some filtration, like has happened over here on the right, what is that doing to those lower energy photons? What's it doing? We add filtration. Yes, it's absorbing them, right? So it's preventing them from trying to interact with the patient. If those low energy 30 and 40, what are they basically going to do when they hit the patient? They're going to do what?
They're just gonna scatter.
They're not going to scatter. They're going to immediately get absorbed in the skin, right? So that's adding skin dose to the patient because they're so low energy they can't do anything else. So when we add filtration, that is stopping those lower energy photons. So what now happens to the average energy of our beam? What happened to the average? It goes up. So relate it to something that's important to you. Your test scores. God forbid those were your test scores. Okay, that would be terrible. But let's say it was. If the teacher is really super nice, not like me, and drops the 2 lowest test scores, what happens to your test average? It goes up. So the same thing is happening with the average energy of the beam. When we add filtration and we filter out those low energy photons, then the average energy of the beam is going to go up. And yes,
Sorry.
no, go ahead.
So why doesn't the filter lower the energy of other beams? You know what I'm talking, the other photons? So,
Because they're energetic enough to get past them. It doesn't stop it. They can penetrate through it.
so I'm thinking like, if you've got, I'm trying to figure out how to explain what I'm thinking. Cause I'm like, if I run through like, at a football game, you run through that paper.
Mhm.
That first person's gonna slow down just a little bit because they're going through the paper. Why doesn't that happen with the rest of
Because
them?
paper and aluminum
are
are
different.
different.
Okay,
Aluminum's not affected like that, like
Okay.
the paper would be.
okay,
Does that make sense?
maybe I got
Like
it.
the aluminum's not gonna give. People that are coming through the paper are coming through at different
Right.
speeds, different energies.
But so are the photons. Sorry, I'm sorry.
but
Maybe
the
I might be
paper-
overthinking.
Paper and aluminum are totally different
Okay,
in their response to that. So that's not a great
okay.
example. I see what you're saying, like you think, well, maybe it would,
slow down your 70 photon rather than,
but it won't because of the energy of that photon. It can't stop that because of the binding energies. We can come back to it.
It's okay.
Did I
It's
see a
okay.
question over here?
Oh, I was just gonna say, like, so why doesn't it semi-absorb it, was what you were trying to get
I
at?
guess,
Okay,
I guess, why doesn't it lower the energy a little bit?
yeah,
But
Because it's not lowering the energy of each photon.
it's
We're talking about the
absorbing,
average.
I got it. It's
The
absorbed, no,
average.
the average wasn't the confusing part. It was, these are absorbed. Why aren't these ones? But it's because that's all it can do. It can either absorb or it can go
That's
through.
right.
Okay.
Yeah.
Sorry, I had,
No, that's okay. Good question. Any other questions about this one? We're gonna see in lab how it affects the X-ray emission spectrum, meaning how does adding that filtration when we touch the front of that collimator, the face of the collimator, how does it affect the quantity of the photons and the quality of the photons? We're gonna see of the spectrum in general. We're gonna see how it affects that. Compensatory filters, page 41, these are special filters for special applications. Now, you may have already seen some places use this, especially like we called it UMG. They're now called Department of Orthopedics, I believe. Has anybody seen them do a leg length study where they're doing the patient from the hip down to the ankle? You seen that? Okay, so they have these special filter that they can put on the face of the collimator because your heart thickness between your hip and your ankle is great, right? I'm a lot thicker up here than I am down at my ankle, and that's the way most people are. So especially with film, can you see how that would be a problem? If you got the technique accurate for the hip, what's the ankle going to be? If it's good for my hip, is the ankle going to be under or overexposed? Overexposed. That's right. And the opposite would hold true. So if I did it good for the ankle, then my hip's going to be underexposed. So you can get the technique set that's accurate for the hip, use one of these special filters, and it sort of gives you consistent thickness across the part so that the entire leg from the hip to the ankle can be visualized on one image. The wedge filter you can see is, let me see if I have another picture in here. Oh, the wedge filter is just what it says, a wedge. So it's thicker on one end than it is the other. Same thing with your foot. Which part of your foot is thicker, the toes or back at the ankle? Back at the ankle is thicker, right? It does like this. Most of the time when you look at a lateral foot, it's doing like that, right? So you could put which end of that, does everybody see the filter? Here's your filter. This is a filter that you would lay on the patient's foot. So would I want the thick end of that filter to be over the toes or the back of the foot?
The toes to even it out.
Exactly. We would want the thick end of that filter to go over the toes so that then the entire foot is what? The same thickness. So that the technical factors were accurate. Now with digital imaging, is it as important? No, because you can adjust the window level brightness to see the entire foot, but you can still use them. And that would save, somebody some manipulating of the image, the radiologist or whoever's looking at it. So the serial step wedge, do y'all see it? It has a little tiny step, then a little bit thicker, and then a little bit thicker. So you would put the thicker end over the ankle and the thinner over the hip, and it just sort of gives you a more uniform thickness of patient. It's to give uniform receptor exposure to improve the image quality. It's not a patient protection device. It does, however, decrease contrast. Do you see how it decreases contrast? Because now what? The part is uniform in thickness, right? So it decreases contrast a little bit, but it did help us be able to see the different parts in the same image. So total filtration is going to be the inherent plus the added. It does not take into consideration any kind of compensatory filters that you use. These filters that you're either laying on the patient or adding to the bottom of the column. This sentence, this last sentence right here, you need to circle it, highlight it, star it. You will see this again. So you need to know this. For tubes operating at 70 or above, you have to have a minimum of 2.5 millimeters of aluminum or aluminum equivalent within the path of that beam. Okay, 2.5. So you're going to see that again, whether it be on a test or in the lab or lab quiz, it's going to be there. The effect on, we have like 2 minutes. The effect on the X-ray emission spectrum. So the way you read this is we have quantity on the y-axis and we have quality on the x-axis. Okay, so you can see X-ray energy is on X, number of X-rays, quantity is on Y. So as we add filtration, so here, let's say we start out with 2 millimeters of aluminum filtration and we double that to 4. What happens to the quantity of X-rays? Look at the chart. What, Avery? There's less. You can see them mouthing it. It goes down. What happens to the quality of the beam? Which way does it shift? If we draw a line, if I drew a line from here down to here for 2 millimeters. And now for 4 millimeters, I draw a line from here down to here. Which way did the spectrum shift? Left or right? To the right. So if it shifted to the right, what happened to the quality of the beam? Did it increase or decrease? It increased, right? Because here, the X-ray energy is about, oh, I don't know, 35-ish, something like that. Here, it's more like 40. So the average energy is going up. The number of photons is going down. They're being absorbed before they are ever directed at the patient. Okay? So here's just a sort of a summary statement of that. When filtration is increased, technical factors may need to be increased to maintain the same image receptor exposure due to removal of part of the useful beam. Meaning, sometimes you add so much filtration that you start to get into those photons that actually could be a part of your useful beam. So you don't want to add filtration to the point that you are taking photons that could be used to create the image out. However, there's a greater decrease in overall exposure to the patient, even with the increase needed. There's no formula for this. No books say, hey, if you add this much filtration, you need to add this much mass. There's no formula. In general, with digital, you can really sort of get by with it without having to change mass. What was I going to say? So the bottom line is, even though you might have to add a little bit of mass, the overall protection of the patient is so improved with filtration that it's worth it. Because if you leave those very low energy photons in the beam, what are they going to do? Just get absorbed right in the patient's skin, and that adds to their skin dose. The last thing is air gap, and we're going to cover that with grids. Not next week because we won't be here, but the next week we'll talk about grids. Okay? Any questions? No, that was a lot. Okay. Give y'all your time in between here.